Sean bienvenidos a un nuevo plano.
Bienvenidos a un nuevo plano.
Un nuevo viaje.
Un nuevo viaje.
Nuevo viaje.
Donde la visión es bidireccional.
Bidireccional.
ARI. Exposición comercial de tecnología oftalmológica.
Hello again. Welcome to ARI 2024 with Topcon Health. This is a satellite Topcon session that will be extremely interesting as far as we have a passion of the company for perfect vision. So this perfect vision will be about the topic to cover and will be covered by distinguished speakers as Jaime Aranberri, Ramin Koramina, and Martin Kolodma from Czech Republic, Soleva, and there will be a debate at the end, led by Jorge Alio del Barrio and Félix González from Madrid. I'm sure that you are going to enjoy a lot this session, and please visit the Topcon virtual stand in our ARI exhibition, technical commercial, that is this moment in our way, and I'm going to I'm sure that you will enjoy a lot visiting this Topcon place for, as far as the interest, the innovation, and the passion for vision of this company. I think that the first presentation will be introduced by Dr. Jorge Alio del Barrio, and please, Jorge, you can follow.
Thank you very much. So we're going to start with the first talk by Dr. Aranberri, lente EDOF sectorial en una práctica multifocal.
Fitting an EDOF lens into a multifocal IOL practice, the Acunex Vario IOL. We started implanting multifocal IOLs 20 years ago, and this has completely changed our practice. First, we started implanting these lenses in cataract patients, and now this has extended to younger patients who want to get rid of glasses for distance and near vision. This revolution was based on diffractive optics, where light is split into different foci due to diffraction. We have now many designs out in the market, either bifocal or trifocal lenses. But there were some limitations. Some light is lost out of main orders of diffraction, and number two, the defocused image interferes with the focused one, creating several issues. And everything, of course, will be worse if there is any residual ametropia. We soon learned that there were some contraindications for these IOLs. Low best-corrected visual acuity, my personal limit is a threshold of 0.8, any pathology that limits visual function, abnormal binocular vision, any kind of strabismus, and highly demanding patients, either for objective or subjective reasons. In 2009, I started using the Oculentis M Plus IOL, and I was very satisfied with this lens due to less symptomatic contrast sensitivity loss and less optical dysphotopsia. But in 2015, we stopped implanting this lens due to some optic opacification cases that affected the hydrophilic material, and we moved back to diffractive IOLs, which has been our standard since then. The last 10 years, new EDOF IOLs have shown up in the market, and they claim to provide good best-corrected visual acuity, reasonable intermediate visual acuity, and less optical dysphotopsia. Right now, we can find many designs of EDOF lenses, so we can choose between a monofocal lens, a diffractive bi- or trifocal with 2 or 3 different foci, or an EDOF where the focus is elongated. We have to be aware that there are different EDOF optical mechanisms So most of them are working on the central optics of the lens, some of them are diffractive, and some can be refractive sectorial, like the lentis comfort, which is a variation of the old M+ lens. So the central optics, these are some of the very well-known models. These are diffractive EDOFs, and there are some hybrids with a central change and a diffractive optics. And my personal experience with these models is that effectively they provide good distance and intermediate visual acuity with less dysphotopsia, but the diffractive EDOFs also present some dysphotopsia similar to diffractive multifocals, maybe a little less. And those working on the central of the optics of the IOL show a slightly worse best-corrected visual acuity than monofocals. So can we still use them in very demanding patients? The last years, I've been working with the M+ Comfort and its evolution, which is the Acunex Vario, where the optical design is the same, but we've got a new hydrophobic material to avoid the risk of the past opacification of the optics of the hydrophilic M+. This is a glistening-free IOL material with a blue light filter and with an optical design with a light transmission of up to 95%. So it's been shown that the optic MTF is very good both for distance, intermediate, and near. In the same paper, we can see that the PSF of the comfort lens for distance, intermediate, and near is very good. These are some monocular defocus curves of the Acunex Vario in 12 eyes of 12 patients of mine. So we can see that the profile is very consistent for all of them, getting a functional vision over 0.8 of best-corrected visual acuity from plus 0.5 to around minus 1.6 defocus. So this means that as close as 62 centimeters, we've got a visual acuity over 0.8. And this clearly tells us that these patients are functional for computer reading with a planar refraction. And probably in good conditions, they will be able to read a newspaper or perform tasks on closer distances. This is a contrast sensitivity study where the Acunex Vario was compared to the Eyhance, showing a very, very nice curve. And the most important of this lens, it's free of optical dysphotopsia. In my experience, these 2 years, we had no patient complaining of optical dysphotopsia. So at this moment, whenever I'm deciding what lens to implant, and if there is no pathology, no issue, and the patient assumes the risk of dysphotopsia and loss of contrast sensitivity of diffractive IOLs, that's what we do. But if not, if there is any pathology or the patient does not want to go with these diffractive issues, then we implant this Acunex Vario EDOF IOL. And my only last decision is to target for plano in both eyes whenever we feel there is a far distance priority, or we target some micromonovision if the patient wants to perform better in intermediate and in near tasks. So here we've got some cases that will illustrate better what we're getting with this lens. This is a woman, 67 years old, with a right eye cataract. She had myopic LASIK 20 years ago in both eyes. And you can see down in the left that the best corrected visual acuity of the right eye was around 0.6 with some astigmatism. So we did surgery with an Acunex Vario toric of 17 diopters, and this is the final result with an uncorrected distance of 0.55, an uncorrected near of 0.7, and some residual astigmatism reaching a maximum in distance of 0.75 and 0.85 in near. This was an extremely satisfied patient, and we all can guess that with a diffractive IOLs, had these been the numbers, the patient probably wouldn't be that happy. This is a similar case of a woman 54 years old with hyperopic LASIK 20 years ago. Here there was no cataract. The patient came to get rid of glasses, and she was a high hyperop with stigmatism, and these were the lenses, and this was the result. And again, we can see that the uncorrected distance and near is quite good. There is some residual astigmatism, and due precisely to this astigmatism, the patient can perform all tasks without glasses. So this is a very happy patient with an achievement beyond the expectations that we created, telling her that she would need glasses for near. This is another woman with a very deep strabismic amblyopia in the right eye, and she had a left eye cataract with a 0.7 vision. So we did a surgery, and she got plano in that eye and with some residual astigmatism. And this patient as well, with only one eye, she can read the newspaper without glasses, which is, again, I repeat, over the expectations we gave her. And finally, this was a normal patient, no cataract at all, high hyperope, slight amblyopia on the right eye. On the right eye, a lentis M+ comfort was implanted, and this is because there is no Acunex Vario over 30 diopters, and this was a 31 diopter. On the left eye, it was a 28.50, and this was the post-op result. You can see that there is again some residual astigmatism, and in this case, as well as the previous ones, the patient is doing life without any kind of glasses. He only needs glasses for very, very fine near tasks, but he can read the newspaper without them. So in conclusion, this Acunex Vario IOL is an EDOF design alternative to other EDOF technologies. This is not a central optics, but it's a low addition bifocal sectorial lens. The material technology seems to fulfill the highest standard demands, and the clinical performance in my first 100 cases is beyond my expectations in terms both of vision quality, visual acuity numbers, and the most important, patient satisfaction. So thank you very much for your attention.
Thank you very much, Jaime. Excellent presentation. Now, it's my pleasure to introduce to Ramin Koramia, who is the co-chairperson of this session. Thank you, Karim, because you have been able to connect finally. I welcome you, and you are the next speaker. Thank you.
Ladies and gentlemen, it's a great pleasure for me to talk at this year's ARI conference. I would like to talk about the Teleon Acunex family of IOLs. Teleon currently has a very broad spectrum of IOLs on the market. Their monofocal lens is called the Acunex. They also have a full vision range IOL, which is called the Acunex Vario Max. They also offer an EDOF IOL, which is called the Acunex Vario, and they also have an enhanced monofocal IOL, which is called the Acunex Quantum. So let's get started and talk a little bit about the Acunex Vario, which is the EDOF IOL, which is provided by Teleon. In the David J. Apple laboratory in Heidelberg, we looked at the optical performance of various lenses. In one of our trials, we looked at the Acunex Vario and compared it to the Pure C IOL, which is also an EDOF IOL with a non-diffractive design, which has just been recently put on the market. When we assess the Acunex Vario and the Tecnis Pure C at the optical bench OptiSpheric IOL Pro 2, you can very nicely see that at a 3 mm aperture, comparable MTF values were achieved for the Acunex Vario and the Tecnis Pure C. When we now have a look at the MTF curves at an aperture of 4.5 millimeters, you can see a clear difference in MTF values. But these differences are only caused by the corneal model with a spherical aberration of plus 0.28 micrometers, which we used in this setting. We only found better values for the Tecnis Pure C because of the minus 0.27 micrometers spherical aberration compared to the aberration neutral lens Acunex Vario. When we now take a look at the through focus MTF curves, you can very nicely see that a similar performance of both IOLs can be achieved for distance. We also noticed better values for the Acunex Vario for intermediate distances of around 1.5 meters to 60 centimeters. When we now have a look at the LogMA visual acuity simulation, which is derived from the MTF area, you can very nicely see that we found better values for the Acunex Vario for intermediate distances from around 2 meters to 33 centimeters. Let's now switch gears and talk a little bit about the enhanced monofocal IOL, which is called the Acunex Quantum in the Teleon portfolio. You all know that enhanced monofocal lenses certainly have gained a lot of popularity over the last years. In the laboratory, we assess the optical quality of the Quantum IOL and the EMV lens, which is another very popular enhanced monofocal lens. When we look at the MTF curves at a 3 millimeter pupil, you can very nicely see that indeed both lenses performed quite well, but you can also see that the Ray 1 EMV performed slightly better compared to the Acunex Quantum. When we now have a look at the MTF curves at a 4.5 millimeters pupil, you can see that the findings changed. Now the Acunex Quantum performs better than the Ray 1 EMV. Let's now have a look at the LogMA visual acuity simulation. You can see that in the far distance both lenses perform very similarly. However, you can also see that there are higher values for the Acunex Vario for intermediate distance. These days, we oftentimes use enhanced monofocal lenses as replacements for monofocal lenses. Therefore, we wanted to make sure in the laboratory that enhanced monofocal lenses, such as the Quantum lens, do not bring any disadvantages in comparison to purely monofocal lenses. This slide shows you the MTF curves of monofocal, enhanced monofocal, and EDOF IOLs at a 3 millimeter pupil. You can very nicely see that the MTF of both enhanced monofocal Quantum IOLs are closer to monofocal IOLs than to EDOF lenses such as the Acunex Vario or the Tecnis Pure C. When we now take a look at the through focus MTF curves, we can very nicely see better values for the Acunex Quantum and the Lentis Quantum for intermediate distances from around 2 meters to 50 centimeters compared to the monofocal Lentis L313. When we now take again a look at the LogMA visual acuity simulation, you can very nicely see that higher values are achieved by the Acunex Quantum, especially for intermediate distances when compared to monofocal IOLs. The best IOL optics are of very little help when the material that the lens is being made of is not of excellent quality. In my opinion, I see a lot of advantages these days to use hydrophobic, glistening-free materials. We can artificially create glistenings in the laboratory setting. We call this a so-called accelerating aging procedure. To accelerate the glistening formation, we first of all immerse the IOLs in a sodium chloride solution at 45 degrees Celsius for 24 hours. We then cool down the temperature to 37 degrees Celsius for 2.5 hours in a water bath. We then take microscopic images and use a dedicated analysis software to count the size as well as the number of glistenings. In the David J. Apple laboratory, we assess the optical purity of various hydrophobic IOL materials. You can very nicely see that in the Acunex material we could not detect any glistenings at all. So in conclusion, I really think that Teleon has done a great job by introducing a new material. I've shown you that the Acunex material is indeed an excellent material because it's both hydrophobic and glistening free. Teleon also offers currently a very large portfolio. With the Acunex VarioMax, they have an excellent full range of vision IOL on the market. With the Acunex Vario, they also have an EDOF IOL on the market, and the Acunex Quantum IOL rounds up the portfolio because it's an enhanced monofocal IOL. And with that, I thank you very much for your kind attention, and I'm happy to take questions.
So we're going to move on to the last talk on the satellite session of Teleon. Is Martin Choleva. He's going to talk us about our clinical experience with the Acunex family of IOLs. Please go ahead.
Good evening, ladies and gentlemen. Dear colleagues, it's an honor for me to share our experience with multifocal IOLs, and in particular with Acunex lenses. Let me just very briefly introduce ourselves. Czech Republic is a country in Central Europe with around 10 million inhabitants. There is a public healthcare system with approximately 150,000 cataract surgeries performed every year. We are located in Ostrava, that is the third largest city in the country, with history of coal mines and steelwork. Our clinic, which is part of Lexum chain, has 10 ophthalmologists and 3 eye surgeons, so we can be considered as a moderate-sized clinic. We provide large spectrum of eye care, but as you can see, cataract surgery is our main focus. Last year we performed 5,800 surgeries, and for the first time we have crossed the 15% mark for the multifocal lenses. Multifocals are not covered by the health insurance. The additional payment for both eyes equals to average monthly salary. On this slide you can see the spectrum of multifocals in our daily use. We use various types of lenses, refractive, diffractive as well as EDOF lenses. From the pie chart is clear that Acunex Vario is the most implanted lens in our practice with almost 50%. I believe that Acunex Vario lenses don't need an introduction, so just very briefly. It's a hydrophobic, refractive, rotationally asymmetric lens which is successfully tested throughout the year. Lens is available in 2 varieties. EDOF version with 1.5 addition and true bifocal with addition of 3 diopters. Both are also available in toric versions. Our colleagues in Brno performed an internal study and compared all available EDOF lenses and their defocus curves. There were 40 eyes for each lens type. In the graph, Acunex Vario lens is represented with the blue line. As you can see, Acunex Vario showed the best results, especially for distance vision, and overall comparable with Vivity lens. We started to implant Acunex lenses in year 2020 and evaluated our results in the small prospective study. We studied 230 eyes of 120 patients, and post-op data were collected 4 to 8 weeks after the second surgery. We measured visual acuity, manifested subjective refraction, and autorefraction. As you can see, there was no difference in preoperative values between the 2 groups. with exception of the group size. Another slight difference was that the lens with the higher addition wasn't implanted in a hyperopic subgroup of patients. Let's review the results. Average autorefractometry values were slightly myopic higher in the max group, which correlates with almost perfect emmetropic manifested refraction. Average uncorrected distance visual acuity was about 0.9 in both groups. Intermediate visual acuity for Vario lens was 0.63 and uncorrected near visual acuity for Max lens was above 0.8. Let me just mention that all displayed values are mono. We consider spectacle independence as the most important metric for multifocal IOLs. In a survey, both groups showed spectacle independence for distance vision. Vario showed independence for intermediate in all patients and surprisingly high spectacle independence for reading. Vario Max showed very good results for both intermediate and near vision. Patients were questioned on their subjective satisfaction with the surgery. All patients were satisfied with the results, and just 11% were bothered with dry eye associated symptoms. All patients stated that they would choose the same surgery and lens again, and all patients would recommend this type of lens to their friends. Contrast sensitivity of all tested patients was within the normal range. There was no difference between Vario and Vario Max group. As we all know, positive dysphotopsias are important consideration in the choice of the lens. From the study group, only 7% of patients stated that they perceive positive dysphotopsia but were not bothered by it. 93% of patients were without any positive dysphotopsias. General contraindication criteria for multifocals are also valid here, but it's important to consider the severity of the disease and subjective tolerance of each patient. Specifically for these lenses, we do not implant Vario lens in moderate and higher myopes and Vario Max lens in PC-dependent patients. Surgeons use both OVD-assisted and hydroimplantation without any problems. Implantation was considered easy and safe by surgeons, both with use of screw or push injectors. For lenses about 26 diopters, the main incisions had to be enlarged to 2.4 millimeters. Lenses below 26 diopters were usually heated with infrared light for easier implantation. For the summary, we found that Acunex Vario and Vario Max lenses are suitable options for achieving spectacle independence for a large spectrum of patients. There was no significant occurrence of halo and glare. Patients had perfect distance vision with very good intermediate or near vision respectively for both lenses. Does the ideal lens exist? Definitely not, but if we try to tailor the lens to the needs, it's always possible to find an optimal lens for the patient. And we find that the Acunex lenses are optimal for almost 50% of our patients. Thank you for your attention.
Thank you very much, Martin. So now we're going to open the debate where we're going to have our three speakers, and also Dr. Felix Gonzalez is with us. He's a leader expert on the field. So I'm going to open the discussion. I'm a user of the Teleon family, and it's true that today we have so many EDOF lenses with so many designs, and I don't know if you agree with me, and actually this is going to be my question to you if you have the same experience, but with today we have so many of BBT, a lot, but all of them, my experience is that in about 1/3 of these cases, the outcome for NEAR is better than expected. Another third is the expected outcome, but another third is usually a disappointing outcome, where the NEAR vision ends up being not that better compared to a monofocal lens, and this is something that becomes a frustration and also a limitation in order to prescribe EDOF lenses. Something that I like about the Lentis Comfort, for example, or the Aconex Vario, is that it's reliable. I mean, you know what you're gonna get, and at least on my experience, I don't usually get that third of basically dissatisfied patients. I get what I'm expecting, and that's something that is good, because then I know what to recommend to the patients. So I was wondering, for example, Felix, to you, that you have a very broad experience with EDOF lenses. If you agree with me or you have other experience, and if that's the case, to tell me what do you think about.
Yeah, thank you very much, Jorge. I agree with what you said. That's the reason, because with the EDOF lenses, I try to do a mini micro monovision, just in order to avoid this patient unsatisfied with the near vision. Okay, yeah, it's a question just to talk with the patient about the expectatives. Okay, with these lenses. Now I'm very interested in this kind of technology for EDOF lenses, and even for multifocal lenses. So my question would be for the I'm have to disclaim that I'm not a user of these lenses. So I would like to ask to the panelists with experience with the Vario Max, for example, when they decide to go further, to go to the diffractive lens, and when they decide to go to this kind of technology. So, because I see that some of you are working with both technologies. So, which is the fact that makes you decide to go to another lenses, to go to diffractive lens instead of this technology?
So first, Ramin, you can answer, and then Martin.
Yeah,
I would like to hear both your opinion.
Yeah, so,
please,
so I personally always go for full range of vision lenses whenever a patient is asking for the maximum of spectacle independence. But there's always no free lunch in optics. Yeah, so whenever you're achieving the maximum of spectacle independence, patients do have to tolerate photic phenomena, and that's more something that we see in full range of vision lenses. When a patient is demanding better optical quality, then I always go for ED or F lenses. But on the other hand, then patients have to accept that they might need reading glasses. I do agree that the mini monovision or micro monovision approach is something that can achieve better near visual acuity, but I would still say to achieve the maximum of spectacle independence in all distances, I would still go for full range of vision IOL.
Martin, any comment?
Hello everyone. So for us, if a patient has some ocular pathologies, then we mainly go for these refractive lenses. We usually do not implant diffractive optics with patients that have some contraindications.
Yeah. I'm going to answer myself, Felix, what is the approach I do. So the first thing to say, this is a refractive lens, so it's very important if you are going to implant it to measure the pupil. Because if you are facing a myotic pupil with, for example, for the scotopic pupil like this small, or photopic pupil less than 3, I usually do not implant it, because actually I've seen, the problem is that if the pupil is so small that it can fall, it cannot use the near sector. So it's very important to check the pupil, and I always do always, if I'm gonna I'm thinking on a refractive lens. So when I'm thinking a refractive lens instead of diffractive, because it's true, to my practice, I would say trifocal lenses are like the baseline choice. But they have a certain indications where, for me at least, under my point of view, refractive lenses can offer me something better. The first of these indications is unilateral implantation. Unilateral implantation of diffractive lenses is not always successful. There is a paper from Baviera Group telling about 10-20% of dissatisfaction with unilateral implantation of diffractive lenses. And this is relevant because it's small, but it is not, because we're talking about 10%. I don't remember the precise number, but this is quite a high number in refractive surgery. But so for me, refractive multifocal implantation is the way to go in unilateral implantation, either unilateral cataract or unilateral refractive lens disease, whatever the region. And actually now I'm doing an article on that regard where we are going to show our outcomes. And the other point where I consider the refractive lenses is what Martin said. Those patients that had a mild pathology or a mild, like moderate aberrations, like for example, post-myopic LASIK, post-hyperopic LASIK. For example, in post-hyperopic LASIK, since you have some degree of spherical aberration and pseudo-accommodation in the cornea, the pseudo-accommodation plus the sector of 1.5 many times achieves you and gives you very good near vision, but with no photic phenomena, and you don't have the risks of trifocal lenses in such eyes that we know that in these prolate corneas do not always work well. So, also to continue, Ramin, I'm going to ask you, because you're far away much more expert than me in IOL optics, and I was going to ask you, what do you think is the factor that is underlying this lack of predictability in the outcome of EDOF lenses? Why some patients achieve better vision, others expected, and others like so, but it doesn't happen with the lens discomfort of my hands, but with all type of lenses, EDOF lenses, the rest of them is the same history. What is the underlying reason that you think could be in relation with this variability in the neural outcomes that we're having with current EDOF lenses?
Yeah, I think that I personally like really to use EDOF lenses, but as you completely said it right, I think that we still also need full range of vision lenses. Yeah, and as I said, in a patient who demands the best outcome in the near distance, I still think that that EDOF lenses are probably not the ideal choice in such a patient. At the end of the day, it always comes up to the patient's expectations. Yeah, we know these days that not everybody is reading books in the closed systems anymore. Yeah, many people are reading on electronic aids, and the print size is rather large. And I mean, such patients are much easier to satisfy than people who really read a lot in the near distance. And this is really what everybody needs to ask prior to surgery to the patient. What is actually the thing that they expect after surgery? Do they do a lot of nighttime driving? Are photic phenomena an issue? And in the worst case, are reading glasses acceptable in the near distance? And when all these factors are taken into consideration, I think that we have great choices these days to satisfy all of our patients' needs.
Thank you, Romin. It's very important to point out that EDOF lenses create less photic phenomena, but they do also. I mean, we have our data with BBT lens, for example, and up to 15% of the patients, they do refer photic phenomena. It is true that it's far way less than with trifocal lenses, but they still do. And something that I like a lot with Acunex Vario is that they do not complain. I mean, it works on patient satisfaction very close to a monofocal lens, and the amount of photic phenomena, you might find one case referring some mild symptoms, as Martin showed, but really this is very anecdotal, far away from what we see with EDOF, where still about 15-20% of the patients can still refer some even halos. No? So Martin, one question to you is, because probably now the most successful lens of Teleon is the Lentis Conforto Acunex Vario. The Vario Max is less spread. In your practice, do you consider the Vario Max in any type of patient instead of trifocal lenses, or you are mainly using the Vario version of the lens?
Yes, so we usually tend to use Vario lenses more than Vario Max lenses. I think it's mainly because of patient expectations. It's for us, it's hard to manage expectations, to explain the patient that, like, or or in our experience, maybe VarioMax didn't always get the full range of vision for the patient, so we tend to implant more diffractive optics. And as the colleagues mentioned, as I mentioned in our presentation, the near vision is with Vario lens is surprisingly good in our experience. So we tend to stick to the Vario lens.
Okay, I think Professor Alio wants to make a comment.
Yes, something that I like from the Acunex Vario is that it's a lens that never disappoints me. I have implanted many, and it's one of my choices when I want to get, for sure, a good result with no halos, no glare, and no distortion, because we know that this type of varifocal optics makes distortion when they reach more than 3 diopters, and this is one problem that we have with the VarioMax. I use the VarioMax in the non-dominant, and in the dominant, the Acunex Vario, if I want to get extra near vision, but in most of my patients, believe me, with the Acunex Vario, I have no dysphotopsia, no halos, no glare, and good vision to the level of printed newspaper characters, which is for most of the patient enough. If we have a very intellectual patient or somebody that really wants to see for near more, then is when I combine with the VarioMax. But believe me, the Acunex Vario, when I want to guarantee the outcome with no complaints from my patient, is one of my first choices, or my first choice, I would say at this moment.
Also, I want to ask you, Ramin, because sorry, Felix, go ahead.
Yes, just a question. Do you have any patient that are not adapted to this refractive technology? Because in the past, when 12 or 13, 14, 15 years ago, maybe, I implant some M+, and I have a very good result, but I remember very well one patient that it changed completely me, because it was a normal patient with a perfect surgery, but she was not adapted, and she was very disappointed. So I don't know if you have find any patient that you have implanted these refractive lenses. Do you have any problem with the adaptation or something like that, like sometimes happens with the diffractive lenses?
Felix, I'm going to answer because probably I am the one with more experience in this debate with these lenses, and I'm an expert in neuroadaptation, as you know. So neuroadaptation, yes, it happened with the Acunex Plus 3, Acunex VarioMax. The answer is yes, we have. This is because of peripheral distortion. Peripheral distortion is not a dysphotopsia, it's not halos, no glare, it's a feeling of the patient about unusual vision. Peripheral vision is not good. They go into a supermarket or a mall, and they see lights to be in the peripheral part of the visual field, very confusing. And when this happened, I had to change the lens. I have to tell you that this is one of the reasons why bilateral Acunex Vario, or VarioMax is not implanted bilateral for me at this moment. But in the non-dominant eye, it's good as far as the dominant has the VarioMax. It has the Acunex Vario, that means the 1.5. So the answer is, as far as you want to gain more, you are more in risk, you get more, but you have more risk as well. So if you want to be conservative, you want to guarantee no patient complaint. The less complaint would be to have a little bit near vision, insufficient for no activities, but Acunex is perfect. You can play with monovision as well, to leave -0.5 in the dominant, -0.75 the dominant. The Acunex is really good, and moreover, it is important at the moment. It's important, is cost effective, because the cost effectiveness of this lens is very high, which is another advantage. I do declare that cost effectiveness is one of the reasons I use this lens much more frequently than any other, because I'm satisfied, I have happy patients and happy pockets of the patients, which is important as well.
Good. So I think it's time to close the session because time is out. So thank you very much to all of you, and also to the Dr. Aramberri that couldn't be with us. So it has been a pleasure to learn from you, and I hope to see you soon. Thank you.
Thank you very much.